Okay, I'm going to go ahead and start. I believe we still have a few participants entering in, but I don't want to take too much time away from the main event. So welcome to all of those of you who are here. My name is Amy Krupel, and I'm the director at the UF Center for European Studies. The UF Center for European Studies is a Jean Monnet Center of Excellence, which is part of the JM in the US network. Just a few housekeeping notes before we begin. Today's discussion will be recorded and available on the UF-CES website. We will have a question and answer session following the presentation, and participants can submit questions through the Q&A button on the bottom of the screen. So again, thank you for joining us. Today we are here to discuss No End in Sight, Epidemic Temporalities and Narratives in Modern Europe. This talk and the virtual series are supported by the EU Erasmus Plus Jean Monnet program, and we would also like to thank our co-sponsor today, Santa Fe College. This discussion is part of the Jean Monnet Chair series, Pandemics in Europe, Political and Social Responses, which explores the political and social implications of the coronavirus in the EU, as well as looking historically at Europe's response to and the long-term impacts of previous academics in comparative perspective. For details on previous talks in the series, please visit the ces.ufl.edu website. I am very pleased to introduce our speaker today, Dr. Dora Varga. She is a senior lecturer at the Department of History and Wellcome Center for Cultures and Environment of Health at the University of Exeter. Her work spans from the politics of epidemic management to public health systems and access to therapeutics. Dr. Varga's book, Polio Across the Iron Curtain, Hungary's Cold War with the Epidemic, from 2018, received the biennial book prize of the European Association for the History of Medicine and Health. And she has written on global infrastructure of diphtheria, antitoxin, the politics of vaccination in the Cold War, hospital care of disabled children in communist contexts, and shifting epidemic narratives in historical analysis. Dr. Varga has recently been working on a research project entitled After the End of Disease, Placing Epidemic Narratives in Focus. This project is an interdisciplinary collaborative effort to rethink past conventional narratives to identify, collect, and disseminate different understandings of disease and their impacts. And today we're very fortunate that our discussion will be moderated by Dr. Beris Mokavidis, who is a professor in the Department of History and Biology at the University of Florida. Dr. Mokavidis studies history, philosophy, and social studies of 20th century biological sciences, especially evolutionary biology, systematics, ecology, and genetics. And with that, I will hand the discussion over to Dr. Varga, who will begin with her talk, followed by a moderated discussion with Dr. Smokovidis and all of you who are participating.
Thank you so much for the introduction, and thank you for having me. So I've been working and thinking about epidemic temporalities for a number of years now, before this pandemic started. And one of the things that took me to this issue was my work on polio and polio epidemics. I wrote about vaccination politics and also polio treatment, and realized that something happened in the early 1960s when successful vaccination was introduced in much of Europe. And I'll talk about that a little bit here and there, but I would like to start out by addressing the question of the epidemic curve, which I'm sure everybody is more than familiar with. And here you can see several renditions of this. And these images are actually from a wonderful article by David Jones and Stefan Helmreich, The Shape of Epidemics, which was published in the Boston Review, where they write a history of the epidemic curve. I highly recommend this. I don't want to go there this time, but I would like to highlight the kind of stories that these epidemic curves tell us. And this is something that Charles Rosenberg has elaborated on in the late 1980s, relating to the AIDS epidemic, of how epidemics have this kind of dramaturgy of a beginning, a crisis, and an endpoint. And you can see here, which I'm sure everybody's familiar with, is the COVID epidemic curve and the kind of flattening of that curve with interventions. And it's visually very powerful. And it also carries with it the threat of a crisis, but it carries with it the hope of an ending. And it's very, these curves tend to be quite symmetrical. And once you pass the crisis point, then the end is in sight. And that passing the crisis point can be due to a number of things. I would argue that this kind of representation, but also thinking about epidemics in this very neat and tidy way, which is, as you can see on the other graph, is not always extremely tidy, but very working with a very clear pattern, is very seductive, exactly because it has identifiable beginnings, middles, and ends. And of course, we always strive for the ending, especially now. I'm sure I'm not alone in anticipating some kind of ending to this, but unfortunately, I don't have, I can't be the bearer of good news even today on this. But more importantly, this thinking with clear endings to an epidemic has, and thinking about this narrative that these epidemic curves tell, have very clear policy implications. If we think about eradication, for instance, that is working towards that endpoint that is, we can see through this narrative of epidemics. There is the flattening of the curve is also working within this framework. And this is how a lot of the policies, very wide-ranging policies, not just COVID-related policies, are conceptualized. It also doesn't only work with epidemics. This kind of narrative and dramaturgy of the crisis point and the relief at the end also is projected to other diseases that might be have a very different trajectory and might work in very different ways. For instance, there is a way in which somebody is declared as cured of cancer. How that works and what that implies when that patient has to go to yearly, monthly, or yearly checkups and remains a patient, sometimes until the end of their lives, and always with that kind of anticipation if it's going to happen again, if it's coming back, if it's really clear, if it's really cured. That phrasing it and thinking about disease within this epidemic curve projected and epidemic narrative projected on other diseases can cause actually real frustration and problems in how these people are how these interactions take place in hospitals and with other members of society, and how patients themselves relate to these narratives. And we could bring in a lot of other examples: the obesity epidemic, which is often this kind of thinking is often projected to things that are not infectious at all, or not even diseases per se. So there is this kind of expansion of the narrative well beyond epidemics, and I think that makes it particularly important to think about it critically of what that means, which I will go into in some detail soon. And another final point that the problem of this seductive narrative, I think, putting aside to the laudable and positive outcomes of actual disease eradication, smallpox, for instance, it's not like I'm lamenting the end of any kind of disease, but I think that by thinking about and pinpointing the end of something and declaring the end of an epidemic does a certain kind of work that I think we need to think about very carefully, because what we need to consider is, but what happens next? What happens after the end? And I'll tell you in a little bit of what I mean, just trying to keep an eye on the time. So how do epidemics end? Well, in many, they can end in many ways and have non-endings in many ways. And I will first like to focus on so-called techno-fixes, so interventions that are some kind of technological, pharmaceutical interventions that put an end to an epidemic as we understand it, or as it's perceived commonly, and then we'll look at a couple of other ways. So one of the things is, of course, treatment. And treatment can, if there is an efficient treatment for a disease, then that transforms the epidemic, takes away that kind of bite that the disease might have, because it becomes something different. It becomes treatable. Even if there is no vaccine developed, and even if it doesn't really go away, it is no longer conceived of as a threat, as a continuous or even an acute threat. And these are two examples here that I brought just to give you an idea of what I'm thinking here. So one is tuberculosis, and we'll come back to this at the end of this talk, which is which we don't think of as something that is constantly present in our lives. We don't think as something constantly present in Europe, but we can see in this map that it is actually there is in some places larger numbers than others. But Britain, for instance, is one of these places there is constant engagement, very low level background engagement with TB, but TB has, doesn't have this early 20th century significance to it. It doesn't have that cultural significance that we know so well from novels and the representations of the sanatoria. With the introduction of antibiotics, that kind of crisis and attention to it is over. It doesn't mean that it went away, and it doesn't mean that it doesn't cause quite a problem for quite a large number of people. These are some of the latest numbers. So we're talking about nearly 60,000 people in Europe alone with who have TB. And the other very clear example is, of course, HIV/AIDS, which went from a very, very severe epidemic from basically that carried a death sentence in the 1980s to a chronic disease that can be managed through a lifetime if one has access to the treatment. So that also created this shift from urgency took out that urgency bit from how we think about the disease. And by now it's as you can see on this poster here from Germany, there is an aim to eradicate it, but also it's something that people have to be reminded of, because it's not there constantly in the forefront of our minds. It's not there as it was in the 1980s. It has become a different disease. To vaccines. So another way that epidemics might end, and there are a lot of examples, of course, of this in the past, is through vaccines. And of course, today, I'm not sure if you've seen in the news, there is a hope, there's a light at the end of the tunnel, as Pfizer and a small German firm in collaboration has announced that they have a 90% efficient vaccine that they have developed. These are Of course, this is a press release on preliminary numbers, but it is, hopeful, and that there is a lot of hope, I think, pinned on the vaccine. There are a lot of political commitments to this, a lot of political um, statements, even giving deadlines that we will have a vaccine by the end of the year. We will have everyone vaccinated by the summer, even though these vaccines are in the making. Putting aside the complexity of developing a vaccine and the phases that it needs to go through and the ethical issues that this kind of accelerated process brings with it that we are witnessing today, the arrival of a vaccine, the licensing of a vaccine is far from the end of the story. I'm sorry to to be such a, to put a damper on the great news of today, but what we can see from a historical point of view, and particularly, so I've used polio vaccination as one of the examples, and this is where I explored this issue. It takes a very long time from the announcement that there is a vaccine and it's efficient to actual vaccination being successful. And here I would like to highlight two things that I think are important. One of them is that vaccines are oftentimes seen as technologies, as liquids or substances in a vial that is either injected or inhaled or swallowed. But I argue that these technologies, the boundaries of these technologies, go way beyond the boundaries of the object itself, and that vaccine cannot be separated from vaccination. And here we can see two images. One is Elvis Presley getting his polio vaccination with the Salk vaccine, as publicizing the successful polio vaccination, and in another one, a young pioneer in Hungary receiving dressed up as the oral polio vaccine, the Sabin vaccine, and another pioneer receiving that in a costume context, actually. So the stories that these representations tell us is the political significance of vaccines that we can surely see today, but also the act of vaccination. It does matter if it is injected, it does matter if it's swallowed. What happens in Hungary, for instance, is that the Salk vaccine, which is always heralded as one of the most successful medical innovations in the 20th century, it just simply doesn't work in Hungary. And this is a very interesting story of failure that combines health systems. It combines access to quality syringes. It combines the overzealousness of certain local authorities who want to prove that they're vaccinating in a Stakhanovite manner, 110, 120% of the population if needs be. And it combines the relationship between the state and the citizens and possible resistance to that, a bit of mistrust from both ways. But in the end, and it's not clear why, the vaccine doesn't work. The vaccine that is deemed to be efficient, highly efficient in laboratories, it seemed to be highly efficient in trials. When you move into a society and the level of a nation, it fails. So there is, I think, the way I think about it is that kind of efficacy that is determined in even large-scale trials, of course, cannot be necessarily translated into a society, which means that the vaccine itself cannot be understood as just the vaccine that is even participating in the trial. It needs to be understood as an object that is intricately connected to power relations, to different members of the society, and it reflects and engages with relationships between the medical establishment and people and the state, whoever mandates it. Because ultimately, vaccines are technologies of trust. Most of us, and even highly trained physicians, have absolutely no idea what is going on inside the vaccines. They're very, very complex. And many times, except for the one that was announced today, many times they are made from the virus or from the pathogen itself. So there is a lot of trust needed for someone to allow this basically unknown substance to be administered into their usually children's bodies, healthy bodies. And it's something that's made out of a pathogen. And there's a lot of other things in it that is not exactly clear what role they play, exactly what they're made of. And one has to trust that it's safe, and one has to trust that it will work. So vaccines then are placed into this nexus of the state that mandates it or sometimes pays for it, the medical establishment that gives that kind of scientific authority to ensure that it works, and the citizens, parents and children at the same time. And I'll talk in a second of why and how this matters when we talk about endings. So the vaccination, just to reiterate the point, the vaccination itself and the arrival of the vaccine does not necessarily mean an endpoint to anything, because it is also dependent on these power relations and questions of trust, not to mention the question of access and existing infrastructure. Just to refer back to the vaccine that was announced today, that needs to be kept at -80 degrees. That is a very harsh requirement for most of the world to comply with, and to make that vaccine, to make it possible for that vaccine to travel and to get to where people need to be vaccinated. Not to mention who pays for the vaccine, how much it costs, and who will have access to it. And of course, another way that epidemics can end is by becoming endemic, becoming a part of our lives, where societies learn how to live with this. Sometimes they become completely invisible, like Legionnaire's disease. It's still around, it's still a problem, but really not many people know about it, and not many people, there's not no funding going into it, there are no campaigns. It's very much sort of hovering in the low background, unless there's a mass infection. And of course, epidemics, as we can see and experience today, change certain social, cultural, and environmental structures. They change the urban landscape. They change daily interactions. Think of the spittoons that are no longer around, or the practice of spitting in general, that was very much around in the early 20th century in much of Europe, but was done away with in campaigns against TB to control the infection. So there are these very long, and this is just, of course, one small example, but the way that we think about disease, we think about infection, that are changed and influenced by epidemic experiences, also have an effect on how we design spaces. Who knows if this will be the end of the open plan office, or how we navigate space. So I think that is also puts into question, you know, the disease does not necessarily have to be present. It doesn't necessarily have to make be present in our thinking. Doesn't need to be present in any numbers, but its impact is there, and that sort of fuzzies these kind of endings even more. The question, of course, then is, in these cases, when a disease is over or ends, an epidemic ends, but in certain cases still around, or still around in some other parts of the world, can we talk about the same disease? How do we define this disease? Is the coronavirus of today the same as the coronavirus of March or even January, when it was only present in China? Is, you know, can we really think about it as the same thing? And here is a very strong example, I think, of how polio has changed from being a very complex disease that was seen in its mostly in its clinical manifestations and treatment regimens. There were hospitals around, there was whole infrastructure campaigns, and this is an American campaign, but there were campaigns across Europe as well, not in Eastern Europe, but for instance in the UK. And there was the disease itself, when the epidemics were in their, if we think about back to the curve, at their high point, polio was an issue that created this kind of fear of a physical change in bodies and a permanent effect. It elicited fear because of there were children involved mainly, and causing disability. So it raised, it entered in this point of a particular point in time after the war, when most nations were recuperating from World War II and really investing in industrial production. So it was a complex issue, together with its virology, together with the vaccine development, together with the technologies that surrounded it, the braces, the clutches, and the iron lungs. And we have successful vaccinations in much of, in a large parts of the world. And the disease moves to the substance in a vial. It is only ever discussed in regards to vaccination, mostly in regards to vaccines, vaccinating teams. Occasionally, usually brown or black children are shown with deformed limbs to elicit some kind of reaction for fundraising purposes. And I'm not going to go into the problematics of, and the usual representation of global campaigns right now, but the other way that we're seeing it is Jackie Chan or Bill Gates showing us that we're this close to ending polio. So this is what the disease transforms into. It's no longer taught in medical schools. It's not something that people come across regularly in a clinical setting. So nobody's trained how to treat it anymore. We see it through maybe as a virus, mostly as a vaccine, or cannot see it at all because we're this close. All we can see is this little gap between the fingers. So the meaning of the disease changes in many ways, but the urgency and the importance assigned to it that was, for very particular reasons, present in the 1950s, which set of reasons are no longer present, that remains. So there is a continuity in these disease meanings, and there is stark contrast. And a very similar thing happens with HIV. If you look at the representations of HIV over time, the patients completely disappear, the activists mostly disappear. You have the virus itself, and you have the red ribbon. And these are the two ways in which we think about HIV, or these are the things that HIV is assessed through. And I'll try to move on, because what I would like to focus a bit more on is, okay, so we have these various ways in which epidemics end, or rather don't end, but then how can we think about these endings, and what does that mean? Well, of course, endings are very messy. They don't end at epidemics will not end at a point. They will not end when a vaccine is announced and is licensed and ready to be distributed. It will most likely not end when everybody, a high portion of the population, is vaccinated. We need to think of endings as complexities which do not go onto this curve and map onto this curve at all. So then what is the end point? Well, there is sometimes, we can see that actually there has been very negligible amount of cases of so-and-so disease for decades. Surely this means the end. Well, here is an example of how that can be reversed very quickly in the early 90s in Russia and the former Soviet republics. What happens is exactly highlights this relationship and the breakdown of trust. The breakdown of trust happens in the 80s. You can see that there's a slight elevation, but what really happens there is that the relationship between citizens and the state start breaking down to the extent that people stop vaccinating their children. And that is what lays the groundwork. On top of that comes the falling apart of the Soviet Union with a huge mass movement of people, resources focused in certain countries and not others. And diphtheria is specifically interesting because vaccination is introduced in the 1950s. Soviet Union is very successful in doing away with diphtheria, and they do have a very good infrastructure in place. So this rise in cases cannot be explained with, well, nothing works in the Soviet Union anyway, because it does work to a point. It does work very well. But that kind of breakdown of trust shows the fragility of these endings, especially if that ending was brought on by vaccination. The interesting thing of diphtheria, of course, is that there is a treatment for it as well. Actually, the treatment came first. It's a very effective treatment. It requires very early diagnosis of the disease, administered immediately. This antitoxin that is actually made of horse's blood serum stops the disease of attacking the internal organs and developing this pseudomembrane that often chokes the victims of this disease. And this is an over 120-year-old biological, so it's been around for a very long time, and it is a treatable disease. It's a treatable and preventable disease, and yet we have this surge in the 1990s. A good number of people die, and we have deaths currently today in Europe and across the world as well. And part of the reason is that the ending of disease, this endpoint, also creates an end to certain infrastructure that is in place. No pharmaceutical company is interested in investing in keeping the production and licensing of this substance, which requires as I said, requires the keeping of animals and a quite rigorous process, because there is no market for it, there is no need for it. The only remaining places in Europe that have produced diphtheria antitoxin until the early 2000s were actually located in Eastern Europe and were state-maintained laboratories. But nobody makes antitoxin anymore in Europe. So that kind of ending brings an end to these infrastructures. It also brings an end to the practice of diagnosis. So even if there is antitoxin available, people would not get diagnosed in time because nobody knows how to spot, that this is diphtheria, not some other disease, and no, it cannot be cured with antibiotics. So there is this, on the one hand, this breakdown of trust that can take the surge in diseases, but there's also this other thing that's going on, that the success also means the withering away of key resources. And very quickly, because we're running out of time, the ending itself. So when it happens, and the numbers dwindle and vaccination is successful, or the disease just disappears, burns out, there might be people who are left out of that narrative of, okay, it's over. So we have to think what kind of work that ending does. And a good example is, again, polio, unsurprisingly, where people living with polio are absolutely left out from Jackie Chan showing that the end of disease, the end of polio is this, we're this far away, when there are actually hundreds of thousands of people still living with polio around the world. What does that mean, that this disease ends, and what does that mean for them? What happens in Hungary, for instance, in the early 1960s, is that matter of urgency is taken out with the end of epidemics, and a lot of people are just left to their own devices because the state is not invested anymore in this disease. So we have to think very carefully what this means, and this could be an issue for the so-called long COVID. And I would argue that these kind of considerations have to be taken into account already at pandemic preparedness planning. And just a final quick point, that of course epidemics are not only temporal, bring up temporal issues, but also very spatial issues. And I would like to mention two things that are interconnected. So epidemics are extremely transnational, and they need international coordination, because of course, famously, they don't stop at borders. So the ending cannot be achieved in one country or even one continent if it's around everywhere else, because it travels, because it needs that kind of coordination. So I think that it does, it also, because of this, it highlights the geopolitical antagonisms, and also the importance of international organizations at the same time. So there's this sort of tension that's pulling it in several directions. The kind of spatial dimension of epidemics, the other end of it is that they're highly local. And they can be localized, and they can become local problems. I've mentioned TB, of how it's seen as a non-problem in Europe. Of course, that is Europe. It is an extremely enormous problem globally. But as is HIV, which might not be chronic in many settings, as it is in Europe or North America. But there is this kind of spatial distancing of ending for one part of the world, and that we need to think about what that means for the rest of the world and what the implications are. for the rest. And that brings us to this question and tension of the difference between urgency of epidemics and which is no longer the case with TB on a global level, especially in as I mentioned, in Europe and North America. And that is not the same as emergency, which we see happening in India, in parts of Africa and China as well. And I will leave it at that, and we'll be happy to take questions. And
okay, so thank you. I'll come on, and thank you so much, Dora. And I mean, so many threads, so much richness to your talk. So let me just say that for 26 years, I've been teaching a course at UF on the history and evolution of infectious disease that was actually very hard to get approved because people didn't think it was relevant. So in any case, I'm really interested in what you're doing, what you did with this talk. I appreciated the themes, the way that you had an undergirding theme of temporality and narrative, and the way in which you explored, you know, the beginning, the middle, and the end, and especially your use of the term dramaturgy, because there is this kind of drama that accompanies each epidemic, and maybe an artifact of the way we as historians have crafted, you know, the way that we perceive these waves of these epidemics. But I do think they're there. Another term that I like to explore is biography. Can we think of these epidemics / pandemics in terms of biography? And you know, biography very loosely means writing life. It does not necessarily have to be a human life, but you know, biographies have that same sense of beginning, middle, and the end. I really appreciated your use of seductive narrative and the way in which you pulled it out with cancer, because that's one of the, I think it's kind of one of the tragedies that we live with, because cancer shapes almost everybody's life at some point. And this idea that you are cancer free because your CT scan or your MRI, or because your chemo is over. And you know, people celebrate these things. The reality is, you don't know until you are able to track every single cell in your body, and we just do not have a means of doing that. So in fact, it's kind of a deception. It is seductive, but perhaps it allows some people at least to live with hope. Wouldn't work for me, Dora, I can tell you that. It just, you know, if I hear a doctor say that to me, I'm gonna go to another doctor because I'm not so easily fooled. But I do think, again, to come back to your use of narrative and the way in which you're drawing on literary traditions, along with a lot of work in STS, Science and Technology Studies. When you talk about the technofix, the vaccines, I mean, you're really drawing on this body of literature, the sense that we can control the narrative through treatments, knowledge, and vaccines in particular. So one of the things I wanted to just pull out from your talk is, you know, I've been thinking about the popular imagination in the way, and let's call it the public imagination or the popular imagination, in the way of shaping those narratives, or perhaps even it's a kind of a feedback loop, creating communities perhaps, but also shaping that narrative. And one of the ways that we may explore the endings of epidemics is when they cease to exist in the popular imagination, right? Or even in visual representations. I teach the polio lecture. I actually use the same Elvis Presley slide. And you know, my students have no awareness. They don't know what this thing is. And at the end, I showed them a photograph of Yitzhak Perlman. And some of them actually know who he is, most of them don't. But in this way, I render polio visible, I try to, and to sort of tap into that popular imagination that here is an individual. Polio has not ended for Perlman or his family, and for, you know, thousands of other people. I think it's, when I saw your abstract, I was excited by the question that you asked about basically how do epidemics end? And more than likely they go endemic. We cease to make them dramatic. You know, there's a kind of a resolution of the narrative or a changing of the narrative. But I want to just very quickly, I didn't want to do a commentary, but I got excited because my first question was actually going to be, you know, did we, at least on this side of the Atlantic, Dora, because remember, most of us are in the United States, I honestly think that it felt, at least to me, that yesterday was this kind of the crisis moment and we just went over it, not just because of Pfizer, but because President-elect Biden appointed this 13-member coronavirus task force. And part of the frustration we have on this end of the Atlantic is, you know, all of the structure, the institutional structures are just not functioning. We have such an erosion of faith and trust in science that there seems to be no way out of that tunnel. So, you know, I want to come back to a question that Amy posed, and she wants to ask you, what are your thoughts on the variations between approaches to the pandemic and rhetoric around pandemics across cultures? And she wants to get at this comparative European and American, because again, we're in a kind of different place, maybe not that different from the UK, but it's certainly different from a place like Greece or Poland, which I track, both of which I kind of track closely. Does the rhetoric vary significantly, or is this bell curve approach universal? So thanks.
Thank you. I think that, yeah, so that's you know, I think that's a very important point to make, that cultural, again, that kind of locality at the same time as almost the universality of pandemics that I think matters. It matters if it's in China, it matters if it's in Europe, and it matters if it's in the US or Brazil, and also matters, you know, how these everybody's keeping an eye on everybody in a way, and how that's perceived, and how then that changes, and how those narratives change that we tell about it. And I think just before I get concretely to the question, I think there is one thing that that is very important, and that's why this kind of bell curve narrative, and more generally narrative, becomes very important in cases like the coronavirus. It's because there is so much scientific uncertainty. There is, you know, some way that we need to make sense of it and to live through it, and that is to create stories about it. You know, how do we tell the story of what's happening, what has happened, and where it's going? I would think that, you know, there is a big difference, I think, in the American engagement and rhetoric around the coronavirus, and that sort of maps onto a slight difference in the way that vaccination is talked about, for instance, because of a very long historical process and the ideas that underpin the state and the political system. The responsibility of the individual and the responsibility of the state or the government is framed very differently than, for instance, in welfare states in Europe or post-welfare states, you know, in Eastern Europe, where there is still there's a very different set of expectations, I think, and the expectations that each, you know, side has map onto very different resistances. So, you know, although the numbers might not be, you know, very different on the whole, if we take the population ratio into account in the UK and the US, and there is, you know, many ways in which this is not going well, there is a very different way in which here it's all about together for the NHS, for the healthcare system that we all love and are devoted to, even though it's crumbling. There is a kind of pulling together, which was very interestingly here was built around sort of World War II idealized narratives of D-Day and of everybody coming together in a war effort, which was totally undermined over the summer, in the late spring of the summer. So that kind of trust is crumbling as well. But you have, other places like France, where that kind of resistance, or the way that it's talked about, is also, showing problems of this relationship between the citizens and the state, and in other ways, the other issues are coming to highlight. Or in Germany, where, one of the places where we might argue that, at least in Europe, it's sort of working maybe the best of all possible ways, but over there as well, the kind of resistance and engagement and pushback against any kind of interventions are coming from very different and also long-standing political traditions of the far right and also the far left, where they meet in this issue. So I think that kind of political that is entwined with the cultural really matters in how it plays out. So in that way, it's very, very, very localized. But on the other hand, there is a constant engagement. Everybody's looking at each other and adopting models and techniques that then unite in a way. And I think that's very interesting of how those things play out. And what the mask means in Hong Kong and China. Hong Kong is different from what it means in mainland China, and it means very different, almost a political statement in the US, while it represents civic duty in much of Europe.
Lisa has a question. Let me try to rephrase it. And it's unanswerable, but it's good for discussion. What role do you think social media has played these days as it relates to our understanding and control of infectious disease? And she says, I know you can't make any solid conclusions, but are you hopeful about the potential it has? Or do you see it more as a place to sow distrust and promote conspiracy theories?
That's a very good question. And I'm also trying now to think that in thinking back on what you said, Betty, on how things just disappear from public discourse.
Yeah.
So there is, social media, for instance, is one of the places where long COVID is constantly present, which I think is very interesting, and that is I think. Could just to try to find some positive note in all this usually very bleak discussion around endings. So just to dial back a bit, these really long-term consequences of epidemics, the people that they affect really gravely, precisely because it's gone from the public discourse. But in fact, it remains imprinted in the bodies of, a lot of people. And if we think of, where the focus and the attention is going related to coronavirus as well, what happened with polio was that it was the activists from these communities that really pushed it into the foreground, that pushed for disability rights, but also the acknowledgement of these conditions and to keep them in focus. And that, I can see that because it gives a space for people who are left out. Perhaps if this ends, there will be plenty of people, if this is a widespread thing, who are living with the consequences of this disease. That can be a platform for that kind of keeping it in the conversation. So I wouldn't want to venture as to make bigger claims about social media, but I'm hopeful that that kind of it gives space for that kind of activism, of course, in its own echo chamber way, and the problems of the unchecked facts and so on.
Two questions, and they are in the question and answer from Evelyn Alexander. Do you think that wearing a mask could become one of the culturally significant changes that happen in the wake of living in a world post-COVID-19?
Well, I think there is actually, historical precedence of how wearing a mask becomes normal, and that is what happens in a lot of parts of East Asia after SARS. So what we think of as completely new, and we're getting used to it, and it's becoming keys, wallet, phone, mask. So this is what we check before leaving the house. This has been around for almost 15 years, over 15 years in certain parts of the world. I just had a conversation, just to highlight, a very anecdotal, but I think it's worth mentioning. I had a conversation with a friend who grew up in Hong Kong, and she said, well, her life didn't change because she always had hand sanitizer with her. She always wiped off everything. If she goes into a lecture hall to teach, she always wiped off the keyboard with disinfectant and, did all that we find now a new practice. She always had a mask, and it was always normal to see people in masks. So, this is just an extension of that. So yes, I can totally imagine that, but it's again, the mask in East Asia was always, as if you were ill or you had any kind of sniffles, you would put on a mask because it's a considerate act towards others, yes, rather than a protection of yourself.
Yes, it's certainly true in Japan. It was unnerving when I first saw it. And then I would go to the drugstores and you would have 10 different kinds of masks. This one has charcoal, this one's better for pollution, et cetera, et cetera. But, I also saw a documentary, one of these video things for social media. And in the United States, there were these people in this rural community in the Ozarks. And every time they saw someone walking around with a mask, they would all turn to each other and say, Democrat. So in the United States, they've become so heavily politicized, they can actually indicate your voting preferences, at least in some people's views. Mm-hmm. So a second question from Barbara Minell. I wonder whether the ways pandemics end relate to the way they begin, or did you find that this does not matter? What I mean is that you emphasize cultural narrative and imagination. Thus, does dramatic or traumatic beginning necessitate a dramatic ending? Or are the ways that pandemics end more determined by science than is then narrativized by governments, the medical establishment, and people? It's a great question.
That's a great question, and I think there is, and it's great because of course, we can't talk about endings without talking about beginnings. However, there is, partly because of epidemiology as a field is a very narrative field, right? You're trying to track and trace lineages of how the virus traveled or the pathogen traveled, and where that starting point is. But there is a lot of I would argue that there's already a lot of effort into pinpointing, where did HIV/AIDS start? There's significant, this is something that is really it's seen as a puzzle, and it seems as an important question to ask. where is it now, or what, what has happened to it, or how do we think about it ending is much, much less asked. So somehow that kind of dramatic buildup, I think there is a craving for that origin point, because that will, give us some kind of explanation of why is this happening to us? Why did this, come about? Is this, and again, that kind of sense making of that kind of uncertainty of, is this a punishment for something? Is this something that we need to change our ways? And there's a lot of conversation about that right now, regarding how humans live and what they do to the environment, and how this is a direct consequence of that. But there is this kind of craving for that endpoint, that it'll all be fine once we have a vaccine, it'll all be fine. That kind of hope, Betty, that you were mentioning, that I really appreciate, because it is seductive, and I'm not arguing that this is all bad. I think we need to crave. I certainly crave an endpoint to this, even though it's wonderful that I can be here with you. But even better would be if there were also, this could be happening under different circumstances. But so I think it's not just the governments that are creating the narrative. I think it's partly the scientific, the epidemiological thinking behind it, which is needed to control the disease. It is a kind of yearning for that origin point, because there's a yearning for the explanation of, why me, basically, in crude terms, and the ending is sort of, once we have that exhalation, that finally, I mean, I became a pandemic refugee in the summer, because I couldn't take being on the island anymore and under these circumstances, and because I'm not a citizen here, but somewhere else, I had a legitimate reason to go home, so to speak. And that exhalation to be in an environment that is not, an epidemic center, and to do things that felt normal, that kind of exhalation. But once we have that kind of exhalation on a mass level, there is still, I think we need to be conscious that there is still, a lot of things around, and a lot of mess, that we mustn't forget about. And I think that's why we need to think about that already now, before we pronounce any kind of ending.
Well, we're almost out of time. I want to close up with two thoughts. One of which is, one of the things that I find so exciting in your work is the fact that you deal with, and let's face it, at least in my little corner of the universe in history of science, we know so little about the so-called Iron Curtain countries. And I was recently, and I'm still involved in a collaboration with a group of colleagues at the University of Warsaw. And it was about pandemics in Poland, because I was there and I taught my course there for them and with them. And one of the more mystifying and yet, and I would say exciting things that I discovered is that when it came to AIDS, because we were surveying the biography of the diseases, the infectious diseases that were so important in Polish history, and Poland is a fascinating country for many, many different reasons, I discovered, I kept pushing them in this conversation. Well, what about AIDS? You guys were alive in the 1980s. What about AIDS? And I realized that in the public imagination, there is very little in terms of AIDS. So if I get back there, one of the things I want to do is to explore the 1980s, because these were an especially tumultuous time in modern Polish history. But it really drove home the fact that we have entire parts of the world. We're always focusing on America, or at least, of course, I'm biased because look where I'm located. I happen to be in Canada at the moment, but it doesn't matter. But there's so much that we can do. And in particular, this period of the Cold War and this region. You know, your talk is for the Center for European Studies. So I want to thank you for bringing that out today. And I just want to say thank you so much. It was very exciting. Historians are always, you know, we don't have chips on our shoulders. We have boulders. We have boulders because everybody thinks that we are irrelevant. And we always try to conjure up the usable past. We talk about it. So if this is not an instance, if COVID-19 does not present us with this, I don't want to call it an opportunity because I don't think it's a good thing, but if we don't come in and, you know, literally draw on the past in the way of helping us understand political contexts, health disparities, you know, I've told people there's something wrong with you if you are a historian of science or medicine and you didn't see it coming. The health disparities, the fact that some people would suffer disproportionately, especially in the United States, right? If you know your history, you can anticipate these things. So, you know, what you're doing is really using the past in the way of helping us understand the present. And, you know, I like to think, I'm going to leave on an optimistic note and say, I do think the light may have appeared at the end of the tunnel. So many thanks, Dora. And thank you, Amy and Lisa and Corinne. And let me tell you, you've had scientists, you've had people in the humanities all over the university attending this lecture today. So
Well,
thank everyone.
Thank you very much, Betty, and thank you, Dora, and thanks to all of the participants. As you are signing off, you will be taken to a survey page. We appreciate your patience to take a few minutes to fill that out. And this recording, as well as recordings of all the previous talks in this series, are available on the CES webpage. And thank you, everyone. Have a good day.